why does this artifact occur? And so that's the focus, is to just show you guys a little bit of an overview of normal adult EEG. So this is kind of relevant, I think, to most people's practice to at least know this part about EEG. What are you really even ordering when you order the test, and what goes into it? So we'll start. We can't cover everything in one lecture, So it's really going to just be like normal awake and asleep EEG. We're going to go over the technical aspects a little bit. Probably the actual texts that are coming. Probably this will seem very basic to them. I do have some disclosures, mainly that I've once in a blue moon give a talk for UCB. It has no relevance to EEG talk. This EEG talk though. And so, we always start with these. Normally, these lectures are these really advanced ICU EEG patterns. And that's kind of what we always go to, is like straight to that. But the theory I have is that, like, before you can do this kind of crazy tricks and, learn the advanced stuff, right, you need to do this. You need to learn the basics, right? You need to learn to walk before you run. And so that's what we're going to do today, is kind of learn more of the basics before we're doing this, And so we're going to just cover the technical aspects of EEG, normal awake EEG, normal asleep EEG. The lecture is really more a little bit designed for people who have never read EEG or have kind of read it briefly, to just get a better feel for what is even happening. So part one will cover the technical aspects of EEG. And a principle that I think is really important is you want to understand how and why, not just memorize the patterns when you learn EEG. That will make you a lot more confident long-term if you take that perspective. So first of all, electrode naming, sometimes that's where you got to start. Like when you're looking at it, like how do you even organize this in your mind? Well, it's actually labeled pretty logically. If it's FP, it's frontopolar, so it's like that's where it is in the brain. F3, frontal. One that will chip you or kind of trip you up is the F7, F8. These are more frontotemporal or anterior temporal, despite being F. The odd ones are left, and the even ones are right. And yes, I did draw this myself, so in case you couldn't tell. And then O is occipital, P is parietal. And when you have something that's like in this region, there's not a lot of coverage for parietal, so it's kind of temporoparietal is pretty common. You see a discharge, you kind of look around this area too. And so this is just to give you a general overview. And of course, you see dead center are the Z electrodes. So that's just to give you some orientation to what you're even looking at if you've never read an EEG before. And so just remember the letter C is for central, T is for temporal, corresponds to the area of the brain it should kind of roughly correlate with. So that makes it a little easier if you just know that right out of the gate. We use this 10-20 system. So just kind of very briefly, what is that? It's the measurement of the head. So it's like 10, 20, 20, 20, 20, 10. So when you space the electrodes from the nasion to the enion, that's how it's supposed to be spaced. And so this system is kind of internationally used, and it's the most common way we organize electrodes, and it goes this way and that way. And so this is really important because you need to standardize where the electrodes even are. So when you have a finding that's kind of generally where it's supposed to be. There are times where we use more electrodes, and but you don't really need to know that for hospital EEG. That's more like epilepsy pre-surgical valve, stuff like that. There are different ways to look at an EEG. You've probably heard this term, montages. Has anyone heard that kind of term? I know I throw it in my reports. I know you've heard it some. But it can be really important to know what a montage is, and it has to do with how you compare electrodes one to another. Every electrode you look at is actually two being compared one to another to kind of filter out some of the ambient electrographic kind of noise, electrical field noise in the room. So the two main ones to know, and I'm going to go over all this kind of briefly to get to the better stuff, but is anterior to posterior montage, and that's like this. It's called an AP bipolar, and it's anterior to posterior, right? So you see these arrows. So this is how the electrodes are compared. FP1 gets compared to F7, F7 gets compared to T3, T3 to T5, T5 to O1. So these are chains of electrodes that are compared. And there's then a parasagittal chain, which is more of like the centroparietal stuff, frontal. And so this is a way that it's called double banana at times, because if you look at it, it kind of looks like a double banana with the way they're compared. This is by far the most common EEG montage. I would say this one's used 90% of the time. But there are times where other montages are really, really beneficial. You might think about it. If you're like near the end of the head here, like in the occipital region, might be really useful to compare this electrode to that electrode to better feel, get a feel for where we are. So there are other montages. The main other one used, the other, I'd say like 10% of the time is called a referential montage. And in this one, you're comparing all the individual electrodes to one set of reference electrodes on either side. Usually it's this kind of ear electrodes. Often you actually compare them to the contralateral ear, but just for the purposes of illustration, that might look kind of hard with all the arrows. So there is an ipsilateral one too. So this one is kind of different because since they're all compared to the same place, you can look for what's highest amplitude. And whatever's highest amplitude tends to be where it was like kind of electronegative maximal or the highest voltage area. So that's kind of a very brief look at montages. There are a lot more than this. There's a Laplacian montage, which just takes like local averages and helps you localize seizure onset. There's all kinds of different montages out there, but these are the two bread and butter ones. And I'm not sure, has everyone kind of heard of these before somewhat? Maybe not if you've never really looked at EEG, but yeah, these are two very common ones, just to give you some graphical reference for it. The other thing is that EEG settings, it's not the most exciting topic, and we'll get through it fast, but it's really important because there are filters on an EEG. And if you have them set all wonky, it's going to look way different than it would normally. So sometimes you can really get fooled if the settings are not correct. So these are just the standard sort of settings. Probably don't really need to memorize this necessarily, but it's worth at least recognizing the role that plays, especially if you read EEG and you see the settings up here. So it's always good to look. And if you kind of know your settings, you might recognize the sensitivity of this one. 10 microvolts per minute is different than back. What we set per millimeter is different than the sensitivity here. And that's because it was just set differently by the technologist. So when you first get an EEG, you want to look through the settings and make sure your sensitivity is not way off, your filtering is not way off, that kind of thing. The notch filter is really important in this country because it looks at the way the electrical current is that's fed to the machine and filters out the 60 hertz frequency, which is very commonly introduced, especially in the hospital setting. So if that's off, you may just see a lot of like extra black artifact from that. So anyway, it's just very basic. There's a recording setup with a signal chain. You have the brain here, pyramid neurons are the most common generator of the signal, and you have an electrode, some paste, and it conducts this electrical field essentially back through an amplifier, filters, converter to computer. There is some filtering actually even before it hits the computer, even in modern EEG, but it used to be totally analog filters. I won't really go through this, but it's just based on simple like circuitry, how these filters work. And you used to do it all on pen and paper, right? So it was just like an actual printer that would just go as you're doing EEG. It wasn't on a computer at all. So you had to set these filters as you were doing the study back then. And that's obviously hard because you can't really go back and redo it. It's done, So if you're kind of, disagree with how it was filtered, it's too late. And the actual frequencies themselves are typically broken down into 4 categories. There is a 5th called gamma, which is really fast, but you don't really need to worry about that typically. Delta is less than 4 hertz. Theta is 4 to 8 hertz. Alpha is 8 to 13 hertz, and beta is greater than 13 hertz. So when you hear these things like alpha rhythm, that's what it means. It is 8 to 13 hertz, and hertz is cycles per second. And to take you back to undergrad at some point. So what would you say like the frequency of this is? If you count, if this is 1 second per block here, this is like 1, 2, 3, 4, 5, 6, 7, 8, and then, it's actually faster than that, right? Because there's still some space. What frequency range would this be in? Patient closes their eyes, greater than 8 hertz frequency here. What would it be? Theta, alpha, beta? See, Dr. Lucy said alpha, he's right. So that's kind of just the very basics for how this is even defined, And so how this is a lot slower, I think you can tell. So maybe like 1 to 2 cycles per second. Is this delta, theta, alpha? Any idea? Anybody? Not Dr. Saab, though. He doesn't get to answer any of these. Yep, you got it. So, okay. So one of the weirdest and kind of confusing things in EEG terminology is that a positive deflection goes downward, which makes no sense, but it's kind of the way it was done. And the way I actually do it is to use this Cartesian system in my mind, where you have 2 electrodes that are being compared, and I kind of think of it like a Cartesian system where it's like positive and negative, and the second one, if it's negative, drops down, and that's the direction it would go. So you name it by like the first electrode, kind of, is it more positive than the second? And then it goes in the direction of the second in a way. So like this mental math is kind of a way, you may not learn it this lecture because it's kind of fast, but if you kind of get this concept in your head, then you'll never make a mistake with it. And so that's something to be aware of. It's just when you're reading about EEG, it doesn't really probably matter for a lot of us with the thing what you're doing. So negative deflection is the opposite. It's like the first electrode's more negative than the second, so then it would go up. Now, confusingly, phase reversals are kind of different. So like a negative phase reversal, the things come together. So you could put like a little minus sign in between. That's normally what like sharp waves and stuff do, is they kind of come together at a certain point on the AP bipolar montage. That's a negative phase reversal. The positive phase reversal is like you could put a plus sign in between the discharge and they go apart from each other. These are a lot less likely to be epileptiform. Sometimes like in neonates and stuff, there are positive abnormalities that are epileptiform, but not typically in adults unless it's just part of a weird kind of gradient of the electrical field that you can kind of see that at some point. Benign Rolandic epilepsy, for example, can sometimes have some positivity to the discharge. So here we have an example again of why this would be. So like typically an epileptiform discharge creates a negative kind of dip. So you have this negative area compared to two more positive areas. And if you do this convention, you compare the green to the red, well, the Cartesian thing is going to go down there on this set, whereas this set, E2, is more negative than E3, so it's going to go up. And if you put that all together, it looks like this. So negative phase reversal based on that negative discharge. So hopefully that, even though, like I said, I don't expect you necessarily to learn it in 10 seconds, but like kind of just let you see there's a method behind the madness to it, you know? And so if we had to say, like, what's the most common system used for electrode distance spacing, a little quick hitter quiz. That's just the basics. We'll get more fun stuff now. Is it the International 1020 system, the WHO 1015, or the International 1015 system? Yeah. See if I can get this to work now. There it is. Look at that. Yeah. And then question 2, what montage system is the amplitude, the area, like how high it is, the area that is the highest voltage in the study? We talked about only 2. We didn't actually talk about transverse, so you can probably take that one off the list. So is it referential or AP bipolar? Referential. So that's just kind of a little, and then what we talked about, what frequency this was kind of highlighted here. And so we said it was out, this part here specifically is out, the formatting is a little off, sorry, it's alpha. And I don't know why that happened. That's not the right answer. That's the formatting of the thing got somehow swapped on me from switching to Mac to PC. All right, so if the first electrode is more positive than the second, what direction is the deflection going to go? Downward, upward, isoelectric flat. So yeah, downward. Tim got it. Again, that's this word. Yeah, positive deflection. Somehow this formatting from the Mac to here is a little off in the answer. So we have to keep me on my toes to tell you the correct answer because that's not right. And then what type of discharge between these two is a positive polarity discharge where you could just put that plus sign right in the middle of it? Yeah, B. There we go. And some references for that. Now we're going to go to the better stuff. So thank you for bearing with us. The texts have showed, and they missed the technical aspects of EEG, but they know a lot more than that lecture showed you guys. That was a very basic overview. So probably Sharon could give you a great lecture on the technical aspects. So, so now we're on to the normal awake adult EEG. And this is really important to know because you got to know what's normal before you know it's abnormal, you know, and you have to look at a lot of normal before you get a feel for the variance of normal. So first thing, simple biophysics, you know, but now the eye has a dipole to it, and the eye is a big source of artifact on awake EEG, and to some degree in a sleep EEG, REM sleep, right? But you need to know this kind of concept where the cornea is more positive than the retina. This creates, in a dipole, what is that? It's like a separation of charge, where one part's more kind of like positive, one part's more negative. The net charge is 0, but it's like a separation in charge. So what happens is when you close your eyes, there's Bell's phenomenon. There's kind of an introduction of a more positive charge near the frontal electrodes, which are the frontopolar electrodes. So you remember, if the first electrode is more positive than the second, it goes downward, right? And so it's a positive deflection, it goes downward. And that's positive because the first electrode is more positive than the second. So what does that look like? It looks like this. This is eye blink artifact. So when you close your eyes, the eyes cornea rolls up, positive charge, kind of up towards these frontopolar electrodes, and you get this dip here. And it's got a really big kind of dip here, but you don't really see it much in the other electrodes, right? And that's because it's like an external field that's being introduced into the situation, electrical field, and it doesn't really carry, you're not getting that much in the back. Or if something happens, like an epileptiform discharge is kind of happening in the brain, you're going to see it often. If it was this high amplitude, it would be very diffuse looking. So that's one reason it's eye blink artifact, is the field is very limited to the frontal electrodes. And so that's the concept of how the eye actually causes this. And then so when you are blinking really fast, it can start to even look kind of weird, like something abnormal going on here. But again, it's really isolated to these frontal electrodes. So this isn't frontal intermittent rhythmic delta activity, old school term, or the generalized rhythmic delta activity, the new school term. It's not that, because it's actually all eye blink artifact. Some centers, they actually use eye leads, which really can be helpful sometimes in certain patients. You're not really sure, because you can just be 100% sure, but we don't do that here. So you kind of just need to look at that like that. And conversely, when you open your eyes, you shift the more negative part up. And if you think about the first one's more negative than the second one, in which direction it's going to go? It's up. And so that's when you open your eyes here. And also, for a little preview, the alpha rhythm attenuates when you open your eyes. So I'll get to that in a second. But here's another example, kind of eye flutter and stuff. And, you'll see that sometimes. This one, though, you see these eye lead artifacts. You can tell our eye lead electrodes. You can tell when they're eye movements, because there are phase reversals in here. So that's a really nice thing to have. Moonzer, did you have that up in Michigan, the eye electrodes? We had that in Mayo. It was super helpful when you're not sure. But, I mean, in general, you don't need it that high of a percentage of the time. So I'm not sure if it's really worth the extra effort. It's one of those things, when you need it, it's great, but is it worth it? I don't know. Horizontal eye movement, same concept. You kind of have your eyes here. If you think about it, when you look one direction, like say you're looking to the left, you're kind of putting this positive cornea more that way, and you're making this area more positive. So it makes it go apart here, using the same concepts of positive phase reversal, whereas the other side's introducing a more negative area, and they come together. And so when you look at a horizontal eye movement, you can see there's like these like right here, one of them goes apart and one of them comes together. So based on that example I just showed you, right, it's going apart here, they're looking left, and you can just tell by looking at the EEG. And that's because the eyes have a charge, and they're introducing this with a horizontal eye movement. So, and then again, you see that same thing here where the person, it's a little bit weird montage. Sorry, I switched it where the temporal electrodes are down here, but again, they're looking to the left kind of temporal area here at their eyes, horizontal eye movement. So it's positive polarity here and negative polarity here on the right. So you can actually tell which direction they're looking just by the charges, and kind of understanding that concept. And that takes us to kind of now you kind of got the basics. Now we're going to move into the first thing you look for. When you're looking at ECG, what's the first thing you look for, more or less? Settings always, but like, is it sinus rhythm? Is it not? There's kind of like, you have an anchoring set of like way you move through it. When the EEG, you're typically looking, is there a posterior dominant rhythm? So what the heck is that? Well, in the wake state with eyes closed, it's thought to be a visual resting state, and it's 8 to 13 hertz again, and it's over kind of the occipital head regions maximally. And there's typically a gradient, anterior to posterior gradient, where the amplitude and frequency are a little bit greater in the posterior electrodes than the interior electrodes. And this is what you would see in a normal EEG. To be considered normal, amplitude and voltage is greater than 20 microvolts. It doesn't really matter much, to be honest, though. I mean, if low voltage, if it's otherwise normal, it's still a normal EEG. It's a normal variant. So you look for this, and you look for eye blink artifact on there, okay? And that helps you see, for one, are they awake? The other thing is it should have some reactivity to where when they close their eyes, it becomes more apparent. And so this is an alpha rhythm you're looking for over the occipital kind of parieto-occipital posterior electrodes is maximal. And you can see this gradient, right? Like it's not very high amplitude. It gets higher amplitude as you move back. That's a normal anterior posterior gradient, more or less, right there. Here's another example. This one's like, you could really sinusoidal and prominent back here in this posterior region. You can see there's a gradient where it gets higher amplitude as you move back. So that's what you're looking for. And then I kind of mentioned earlier, when you close your eyes, this visual resting state of the brain is thought to become more active, and hence you generate more of a posterior dominant rhythm at that point. And so there's reactivity of the record, and this is an example with someone's eyes are open or kind of looking around open, and they close their eyes, and all of a sudden you see this posterior dominant rhythm. It's not always this good, unfortunately, when you look at a study, but that's what you're kind of looking for, is reactivity to the record. Reactivity is a normal finding, and when it's unreactive, you can have these same frequencies and it can be extremely abnormal. If you just saw these alpha frequencies diffusely and they're not reacting, it's a very abnormal coma pattern. So the reactivity is a big part of it. And, an example of like attenuation with eye opening. So it's like when they open their eyes, it's deflecting upwards here, negative deflection. And you see this goes away. Like they close their eyes, it kicks in, they open their eyes, it goes away. They close their eyes, it comes in. They open their eyes, it goes away. So this is generally what you're looking for with a normal reactive posterior dominant rhythm. This is like the bread and butter of a normal awake EEG is looking for this and locating this. And so just more examples. This is the best graphic I could find for the tongue, is this clown mouth, but it's kind of the reverse of the eye where it's a little bit more negative anteriorly. And so long story short, when you are moving your tongue around talking, this introduces a lot of artifacts to the record. And that's why it can be really important. Our techs are really good at this, like you're documenting what they're saying or that they're talking or doing this la 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 thing to get a feel for this glossokinetic artifact or from the tongue moving. And that's really important because sometimes it can look like diffuse slowing on certain studies and really fool you. Like, oh, this person's like wide awake and they have diffuse slowing. They must have some encephalopathy going on. Well, no, it's just artifact. And so, I mean, this is a really good one that I saved because it's so good. It really looks like it's kind of, generalized rhythmic delta or something, but it's just the patient was well identified by the tech to be talking. You could see it and it correlated. So here's a less kind of clear one, but it looks like some kind of diffuse slowing intermixed here. And it's just talking. So that's a really common source of artifact, kind of the eye, the tongue, and then the muscles. You see the myogenic artifacts all the time. When you use your muscles, it generates a lot of electrical activity, electrical fields. And they typically look like these kind of dark, black, if you read it black and white, very high frequency waveforms like this on the EEG. And this is kind of all of our greatest enemy a lot of times in the recording, because sometimes in the inpatient side, it's really hard to relax people, and that's what it kind of takes, is to relax their face. And so it can be very tricky in someone who's encephalopathic and stuff. And sometimes that can just, despite all our best efforts, can kind of limit what we can say about a given study if this is really prevalent, because we just can't necessarily be certain about something when it's just this, maybe more than this. I think we could interpret this one, but when it's just really diffuse, it can be hard to interpret. This is another example of myogenic artifact or muscle artifact, this black stuff. Again, here, when you chew and stuff like that, it can look pretty rhythmic. And so that's important to know. And then this is often like a forgotten about normal rhythm, mu rhythm. And often sometimes people think this looks really angry and kind of scary. And it's like, so this is more of a resting part of the brain correlating with limb movement. And so you can actually block the rhythm by just even thinking about moving your limb on the contralateral side or moving it. And so it seems to be some type of resting rhythm of kind of the motor region for that. And so it can be but one side or both sides of the study. And it's usually kind of more of the parietal region, central parietal regions, and it's really arched kind of like. And so this is a good example of it. This is parietal, right? And it's just very arched kind of like here. And it's usually about 1 hertz slower than the posterior dominant rhythm. And sometimes people are like, wow, it's like a just burst discharge of something bad, but this is a normal thing. And here's another good one where it's kind of arched right here. And you see that. And it's really cool. I mean, you can sometimes look and see if someone like moves their arm or something, they'll block it. So, or on the other side left in this case. So this is just something to know about. And this isn't necessarily anything to worry about. And it's not anything to worry about. So lambda waves are another very normal thing in awake EEG. They're sometimes forgotten about. I've seen at least once where, not here, not at this institution, where this was like an abnormal finding was sent with a young person with occipital discharges, and it was all just lambda waves for a patient I admitted to the EMU when I was in fellowship. So it's rare to misidentify, but it can. They literally look like lambda, and they're visual scanning phenomenon, and they're going to see them in the posterior regions, more common in childhood. And they look like this. See these little things? You guys appreciate that? Like, I mean, they literally look like little lambdas in the back of the head. They look very similar, if you read EEG at all, to posterior occipital sharp transients. And actually, if you see more of these on an awake EEG, you will see more of the post on the sleep EEG as well. So this is something to be aware of. Now, these are not abnormal, and so you got to be careful. And if you, I'm going to show you what they would kind of look like if you had the electrodes go all the way around the head in a second. Here are more examples. So you're only seeing this part with the way the EEG is set up in an AP bipolar montage. If you then like put another electrode out here in space somehow and could like get this in between, this is how it would look. There's actually a positive polarity. Or if you compare this to that one for that example, for that matter, potentially. So there's a positive polarity of these things when you do this. And so it's not a, like we talked about, epileptiform things are typically negative polarity. So it's like the reverse of this. They don't go apart, they go in towards each other. And so that's like, this is an example where I did this trick for you, or like this, added this extra electrode to kind of compare it to, and you see how these would go apart, where you could put the little positives in there. So this is sometimes where like a more advanced montage may come into handy, but just to kind of give you the concept for that, of why that would be called a positive discharge. All right. So if you close your eyes, is there a positive or negative deflection in the frontal EEG leads? Which direction does it go? Remember, the cornea is more positive. That would be the first electrode. So anyone venture to guess? So positive deflection, downward. Let's see if it's, there we go. This one's working. Remember that? Down. That's when you, okay. And then in this highlighted region, which direction is the patient looking? Remember, the more positive polarity area is the way you're looking towards on horizontal eye movement. So they're looking towards the odd one. So they're looking towards the left, right? And then when is the alpha rhythm most pronounced? With your eyes open, when your eyes are closed, or with mental concentration? Yep. All right. Heck yeah, we got, that's off. That's the formatting, eye closure. So I need to just like get a PC to run this on before I come out. Yeah, sorry about that, but even better, you got it right. So that's the vertical eye blink, eye closure again, and then you have the alpha rhythm. So that's a big concept to take away from the normal one. And we have more to come. Wait, there's more. There's more fun to be had. Kind of getting a little short on time, so we're gonna get through as much as we can in 10 minutes, and then we'll leave it for another day. So a sleep EEG is really important. You see more abnormalities in sleep. They're relaxed. There's less artifact, and but there are a lot of other little normal findings that will kind of trip you up. Drowsiness and N1 sleep are really a continuum of the same thing, and so it's important to really. There's a lot of kind of different ways people do it, but I think that's the easiest way. The more I did this, is just think of it as the same thing. And when you start seeing positive occipital sharp transients, vertex waves, you know you're kind of in a deeper stage of N1 sleep or drowsiness. You typically have these slow roving or rolling eye movements where the eyes kind of slowly go back and forth, and you have attenuation of all like the muscle artifacts because they're getting more relaxed. And then the alpha rhythm will start to slow, and that gradient will kind of start to go away somewhat that we were talking about earlier. So this would be an example of someone who's drowsy, and these are slow roving eye movements where they're kind of just slowly. So right here, they're looking to the right. Here, they're looking to the right. And so like, it's basically like here they're looking to the left. So it's like going back and forth very slowly, back and forth. And this is like a natural thing you do when you're drowsy. You don't know about it or think about it. And so this is a good way to identify drowsiness. And then you see them again here. These are what these are. And then you also may get some bursts of theta during drowsiness, like slower discharges. It can sometimes look a little rhythmic or whatnot. It's nothing to really worry about. It's gonna be normal. It's just normal thing. And then a really defining feature of the positive occipital sharp transients. They're very similar to the lambda waves on how they look on an EEG. You just happen to be in drowsiness or sleep during when, because you're no longer visually scanning objects. You're asleep or drowsy. So they can occur in trains sometimes, and that can be a little confusing. But in general, they are only seen in those intact vision. So people who are like blind from birth wouldn't really produce these. And this is what they look like, kind of like the lambda waves, or these same kind of thing. If you were to put another phantom electrode or different band montage, you might see it's a positive polarity finding. So these are normal in sleep, and you're going to see these a lot on your EEGs. And then vertex waves are a little bit easier to mistake for an abnormality, especially in a young person, because they can be really sharp, and they're like centrally predominant negative polarity discharges where it comes together, and they can look a little bit angrier. See these things here, and this person is actually in stage 2 sleep based on the sleep spindles, but this is what we're kind of trying to show you. And they are maximal at CZ. Sometimes it's really helpful to look at different montages with these if you're not sure, because they can look a little asymmetric once in a while. It's very rare to have a central sharp wave on an EEG. Does it ever happen? Yes, but you always want to be really suspicious that it's something else that's a vertex wave if it's during sleep and you're not seeing it during wakefulness or anything at other time. I mean, that's a part of Malsby's rules, which is like a rules on when to call an abnormality. It's kind of old school at this point, but that was one of the main tenets actually, is don't call a central thing, unless you're really sure, and as an abnormality. So that's what they look like. Here's a different montage. Sorry, it's a little confusing, but this is central CZ again. Is where it comes together maximal. Sometimes you get like a big burst of them in a young person. It can look pretty wild, and I cranked up the sensitivity a little bit on this to make it look worse than it really was for this purpose. But you can get ones that kind of mimic you being a sharp wave or a seizure or something, but they're really not. They're just bursts of these little trains of vertex waves. Again, the key is that they're really predominant. CZ is where they're maximal. And so those are the defining features of N1 sleep, drowsiness continuum. N2 sleep is kind of the textbook sleep morphologies. It's a deeper stage of non-REM sleep. This is a great time to see epileptiform abnormalities, very more common during this stage of sleep than when you're awake. And the positive occipital sharp transients and vertex waves may continue, but you define the stage of sleep by the more advanced kind of finding you're seeing. So if you see a sleep spindle, then you're in N2 sleep, even if you're still seeing vertex waves. And these are kind of fast, spindly-like waveforms, which range from alpha to beta frequencies, and they're usually about 1 second in duration. You do get people with these really pronounced long sleep spindles. It's kind of more common in some pediatric cases who have other kind of things going on with their brain. But they're more of a cortical thalamic firing phenomenon, and this is what they look like. And this is something that sleep doctors look for as well, to kind of help to find their stage of sleep, these same things on a more limited electrode array. But you're looking for this to be sure you're in N2 sleep. And it's really nice when you get EEGs that do have this stage of sleep, because then we know we've gotten a great look for epileptiform abnormalities. So if you have an outpatient study and you get to this stage of sleep, that's really reassuring. It doesn't mean that they can't have epilepsy, of course not, but it's a much better EEG, much more likely to see something if you get sleep than one that's just awake. Again, some spindles here. They can look a little more subtle, like these variants is a little more on the slower end, and they're a little more subtle. So sometimes it's you see a little kind of cave complex helping you out, but when they're more in that 11 hertz aspect of the frequency range, they can be a little easier to miss. K complexes are these high amplitude discharges. They are probably called knock complexes originally, but no one really knows truly. But when you knock, you can actually make someone have one. They're sort of a system that helps keep you asleep when there's a noise. I'm sure I have a lot of these K complexes right now when I'm sleeping with this young baby, and I had this oxygen alarm going off all the time, and eventually I just slept through it. So I assume I had K complexes going crazy. And this is what they look like here. And this isn't slowing that's abnormal or anything like that. This is a normal feature of sleep. And I always think of it kind of like your head went back and forward, and that's very unscientific, but it's kind of what how Dr. Schuster actually told me to think about it. And that just stuck with me. And so, but you see these a lot in normal patients. This is what you're looking for to be sure what stage of sleep you're in. And so, anyone who also interacts with sleep studies, this stuff's kind of helpful as well. And then there used to be this concept of N3 and N4 sleep, but now it's just slow wave sleep. And if you have at least 30 seconds of sleep with 20% or greater polymorphic delta activity, you're in slow wave sleep. Polymorphic means like it's not like rhythmic. It's like actually like kind of varies in the way it looks from each waveform to the next. So this is thought to allow for memory consolidation, recovery of the brain. The more we've learned about the lymphatic system and everything, there's a lot that happens when you're asleep in terms of clearing out abnormal proteins and substances from your brain through the brain's version of the lymphatic system that was kind of not known about till maybe 5 years ago. So get your sleep. Telling myself that right now, but yeah, it's really important. There's some thought is kind of this serotonergic activation as well plays a role. I don't know, but long story short, this is what it looks like. You start seeing a lot more diffuse delta slowing in the study. It can kind of look like the K complex is just becoming much more prevalent in the study sometimes. And this is another really good time you can look for abnormalities. Certain benign variants, we'll get to that next lecture probably. Some of those go away at this stage. So if you're kind of like, oh, is this benign variant or something that's an epileptiform abnormality, this can be really helpful as a time to more adequately determine that. So you still see some sleep spindles, but it's defined as slow wave sleep because of the delta involved here. And then REM sleep. This stage of sleep is really relevant to all of our practices because we see a lot of REM sleep behavior disorder and alpha-synucleinopathies and neurodegenerative disease. But it's rapid eye movement sleep. It's typically kind of a dream state, and it's pretty easily seen on EEG because you have both they're very characteristic looking eye movements, and they're also something called sawtooth waves. So you can pick this up by looking at these kind of horizontal eye movements during sleep, which are very characteristic, kind of high amplitude, often have lateral rectus kind of artifact in there. And then sometimes it's a little more subtle though, and it can kind of look almost like they're awake. So it's kind of helpful if you know where they are in the sleep cycle when this happens. And then you have these sawtooth waves, which are these things here that can kind of clue you in, usually more central predominant. And here's some of the eye movement still kind of subtle. And so these are the things you're looking for REM sleep, sawtooth waves, to be sure that you're in sleep. You can have some weird transitions back to wakefulness. And this can become a real conundrum sometimes if someone has kind of nocturnal frontal lobe epilepsy and they're very subtle EEG findings to start with. Because sometimes it's just these arousals that you're looking for and you're trying to figure out, are they arousals with some like purposeful movement? Or are they seizures? So this can be tricky because when you alert, you can get some burst of like delta and kind of reactive phenomenon and a profound alerting response, which is actually not necessarily abnormal. And so what you want to look, and sometimes they can evolve a little bit, which can be really tricky. So you really sometimes have to correlate the actual state, what's happening, to be sure. But that's something to at least be aware of. And then we are in the final home stretch for those who have clinic. What type of waveforms are these highlighted here? Well, the person's not like wide awake, right? You don't see any eye blink or like horizontal eye movements really. So they're probably drowsy or asleep. Plus, that's the title of this section of the lecture. So they're probably positive occipital sharp transients, which is incorrectly labeled again because of formatting, and keeps me in my own toes. I have to just know the answer. I can't rely on that. And then is this patient awake or asleep? Looking at this study. You got it. And then what stage of sleep does this record indicate? Was K complexes and sleep spindles present? You got it. And what stage of sleep is this patient in with these kind of rapid eye movements going on? Yeah. So long story short, before you can do this, there's a guy running a waterfall here in a kayak. Before you can do that, you need to learn the basics, right? So the EEG is, I think the more you kind of solidify these basic concepts, the more you're going to be comfortable. We all come across EEG, especially inpatient. It's just kind of a part. It's like the one thing we really do procedure-wise anymore inpatient. So I think it's good to just have at least some of the basics down, and we'll keep working on it. There's the babe, one step at a time. She's off the oxygen now, so that's a big step for us. And appreciate you guys' attention. Thank you for coming. Any questions? All right, good. Everything was 100% absorbed. My job's done here. All right, have a good day, everyone. Thank you.
Thank you.
No problem.